HSC 114, Intro to Pharmacology, Appendix A, Cancer Drugs. This is not a typical chapter. This is known as an appendix, but these are important drugs to know. We're going to go through, we're going to talk about terminology associated with cancer, as well as the different types of medications used to treat cancer and complications of cancer treatment. So first, identifying terminology. Neoplasm is a term that means a new growth. So cancer is considered to be a neoplasm. When we're talking about cells that are abnormal, there's two different categories. One is benign, which means it's a non-cancerous neoplasm. The other is malignant. Malignant is a cancerous neoplasm. All malignant neoplasms are classified as cancer. Now, cancer can spread, and that is known as metastasis, when it spreads outward from the original site. Uncontrolled cell division and metastasis to other parts of the body are identifying characteristics of cancer cells and malignancies. As cancer cells invade tissues and organs, normal function is compromised and sometimes impaired to the point of death, unless treatment is begun with chemotherapy, drugs, radiation, surgery, or combination of these. Reviewing the different types of treatment for cancer. There are three primary types of treatment. The first being a cancer chemotherapy drug. There are other terminologies that we use, such as anti-neoplastic, which means against a neoplasm. Radiation therapy can also be used to treat cancers. It can be used to shrink tumors, or it can be used after using chemotherapy drugs or surgery. So surgery is the third. Surgery can be used to remove a solid tumor. So if somebody has breast cancer or stomach cancer, the cancerous tissue could actually be excised. That's the surgical term for removal. Now, what type of treatment used for cancer is determined by a couple of different things, including what is the type of cancer and what stage is that cancer at. So type of cancer, again, if it's a solid tumor, it might be able to be removed. We could excise it through surgery, or maybe the tumor could be shrunken using radiation therapy. Certain types of cancers that of the blood, those are known as diffuse tumors. Surgery is not going to be effective for that. Now, there are certain characteristics of cancer cells. They're not part of and do not contribute to normal structure and function of the body. Once a cancerous cell is formed, it stops functioning as a normal cell and takes on characteristics of a cancerous cell. First is they are not arranged in an orderly fashion like a normal cell would be. So it's a very disordered arrangement. They often divide more rapidly, so we call that prolific reproduction. And then they also can grow increased blood vessels, which will take nutrients and blood supply away from the surrounding tissues so that it can continue to grow. And then cancerous cells can be very invasive. They penetrate the normal tissue around them and can interfere with the function of those tissues and destroy normal tissues. Now, I know here we're talking about cancer, but I want to just go back and talk about a benign tumor as well. They can also cause damage without being cancerous. Just by the growth can push on healthy cells and damage them. But we're talking about cancer cells here. Talking about your body's ability to identify abnormal cells, one of the things the body has is something that's called a suppressor gene. So the growth of cancerous cells cannot be easily controlled by the body, but we do have a defense, which includes those suppressor genes or suppressor cells. They are meant to repair cellular damage and keep a cell from becoming cancerous. It includes the type of a lymphocyte known as a natural killer or NK cell that will detect, engulf, and destroy cancerous cells. We also have lymph nodes in our immune system that filter cancerous cells from circulating in the lymphatic fluid, as well as white blood cells known as macrophages that are in the lymph fluid that can destroy those abnormal cells. There's also a chemical known as tumor necrosing factor that comes from those lymph nodes that can cause cancerous cells to die. Now, when there's cancer, the body's defenses can become overwhelmed by the cancer, and cancerous cells that are not destroyed will go on to multiply and eventually metastasize. The term primary site refers to the area where the cancer cell grows first. If the cancer cell is contained in that site, it is considered to be in situ. In situ is a Latin term that we use, and it means a contained component. When there is metastasis, or the cancer cells start to spread, they get carried to other parts in the body, either through blood or lymphatic tissue, lymphatic fluid. When a cancer cell metastasizes and it's carried through the blood or the lymphatic system, it can go to a secondary site in the body. So, for example, if someone has liver cancer, that metastasizes and then it goes to the brain. Now, when it's treated, it is still considered to be liver cancer, even though it's now in their brain. So that secondary site is where the cancer goes outside of where it began. And then earlier I referred to the staging as one of the components in determining treatment. So the extent at which the cancer has spread is known as the staging. So when it's in its earlier stage, stage 1, it's contained. It's considered to be in situ. Stage 2, it starts to invade the surrounding tissue near the tumor. Stage 3, it gets to the lymph nodes, and stage 4 is when it's metastasized. Now, the term remission means when the cancer is no longer active, they're not reproducing. This is usually accomplished through treatment. And patients, once they're in remission for at least 5 years, at that 5-year mark, they actually consider the patient cured of that cancer. Even if it re-events in 8 years, it's considered to be a new cancer. So the goal in the chemotherapy is remission. Chemotherapy is a term, if we're looking at the pure definition of the term, any drug, aspirin, is chemotherapy. We're treating something with a chemical. We commonly use this term when we're referring to cancer chemotherapy. There are other terms that we use that mean the same thing, including anti-neoplastic drugs. So again, the anti is against, and it's against a neoplasm, a new growth. So anti-neoplastics. These can also be referred to as cytotoxics. They damage or kill cells. They're damaging. They're toxic to cells. That's a good thing when it's a cancer cell. Unfortunately, some of these drugs can also be damaging to human cells. Now, all chemotherapy drugs are considered to be hazardous drugs, which are usually abbreviated with the abbreviation HD. I'm noting here about USP 800, which stands for United States Pharmacopoeia Chapter 800. These are guidelines for handling all hazardous drugs. Now, all chemotherapy drugs are hazardous drugs, but there are more things in the hazardous drug categories other than chemotherapy. The important component of this, people who go into pharmacy, this is something that we're very familiar with, dealing with USP chapters. These are enforceable, but specifically USP Chapter 800 gives guidelines, enforceable components from manufacturing all the way through nursing and administration of the drug. So it's a pretty comprehensive chapter to be availed of. Now, chemotherapy can have an impact on healthy, rapidly reproducing cells. It's meant to be absorbed and to damage cancer cells which rapidly reproduce. So unfortunately, in our bodies, we also have cells that rapidly reproduce that will absorb more of these cytotoxic drugs, which can cause some problems with healthy cells. Most of those are going to be things rapidly reproducing epithelial cells. It can cause problems with nausea. It can also cause hair loss, alopecia, and bone marrow, the blood cells that are produced in bone marrow. So, like I said, GI tract, hair cells, blood cells are going to be impacted. Adjuvant therapy refers to chemotherapy, or it could be radiation therapy that is given to a patient after they have had surgery to remove a tumor. The purpose of adjuvant therapy is to aid in eradicating any remaining tumor cells. And the term palliative care is using something to treat symptoms, to improve quality of life. They're not meant in treatment of the cancer. So the goal is to decrease symptoms because we can't treat the cancer. Now we're going to talk about classes of chemotherapy drugs. The textbook actually covers 12 classes of chemotherapy agents, several of which of these have subclasses. Generally, when I'm teaching pharmacology, we kind of group them into about 5 main groups, but we're going to go through these and identify what they treat in an example of a prototype from these classifications. So these are the 12 classifications. We're going to go through each of these and talk a little bit more about them. So starting with the alkylating agents. Alkylating agents include nitrogen mustards, nitrosourea drugs, and platinum analogs. So nitrogen mustards, these originated from actually mustard gas from World War I. These are effective in treating leukemias and lymphomas, which are considered to be diffuse tumors. These are types of blood cancers. And the prototype drug is chlorambucil, which is known by the brand name of Leukeran. The nitrosourea drugs are used to treat brain tumors as well as Hodgkin's lymphoma. And the prototype drug, it's lomustine, which is gliostine. And then we have platinum analogs, and these are used primarily to treat ovarian cancer, and it includes drugs like cisplatin and carboplatin. Carboplatin has a brand name of paraplatin. We want to be careful because we do have a lot of look-alike sound-alikes, like I said. Cisplatin, carboplatin, paraplatin. Now your platinum analogs, yes, they are related to the heavy metal platinum. They have the drug stem of platin. And then there are other alkylating agents, which include the drug bisulfin, which is known as myelin or bisulfex. Next on the list, again, your textbook likes to alphabetize things. I may not have put them in these orders, but I'm going to go through them in the order that the textbook has them. So the next ones are angiogenesis inhibitor chemotherapy drugs. They inhibit the growth of new blood vessels. So angio means blood vessel, genesis means start of. So we're going to stop the cancer from making new blood supplies, which means it's going to help starve that cancer cell. This helps also increase levels of interleukin and interferon, which are some of your body's own immune chemicals from the immune system. They will also decrease secretion of cytokines, which lends towards decreasing inflammation. These drugs are used to treat several kinds of lymphomas and also multiple myeloma, which is another type of diffuse tumor or a blood cancer. Thalidomide is the most common or the prototype drug, and it's known by the brand name of Thalamid. I'm going to make a little extra note on this. Thalidomide, patients who receive it have to be part of a special program. This is very damaging to reproductive health and can cause birth defects. It was a drug that they tried to use in the 1950s, and it caused severe birth defects, and we didn't start using it again until the late 1990s, early 2000s, when we found it had a benefit as a chemo drug. Now, the drugs in the angiogenesis inhibitor, many of them end in the drug stem of lidomide. Your antimetabolites are another of the main groups of drugs that are used. Now, there are subgroupings, and there are 3. We have folic acid blockers, purine analogs, and pyrimidine analogs. So, folic acid blockers are used for leukemia and non-Hodgkin lymphoma, as well as lung cancer and breast cancer. And the prototype drug is methotrexate. We've talked about this drug when we discussed rheumatoid arthritis. So this can be used for cancer, but it's also used for other things. It's available by brand names Trexol and Zepmep. And it will have a drug stem for the folic acid blocker antimetabolites of Ext or Xate, methotrexate. Your purine analogs are used to treat leukemia, and the prototype drug is mercaptopurine, which is known as Purixin. And then your pyrimidine analogs, fluorouracil, which is kind of challenging to say. It's commonly referred to as 5-FU, and it's known by brand names of Effudex, Fluoroplex, and Serac. This drug can be given as an IV, but it can also be applied topically for certain types of skin cancers. And we have cytarabine or terabine as the drug stem, with the exception of fluorouracil. Of course, that's going to be something different. But examples of other drugs include capecitabine, cytarabine, and gemcitabine. So just so that we see that cytarabine or tarabine drug stem. The next group of cancer chemotherapy drugs are biological response modulator drugs. These include interleukins and interferons. So interleukin is a chemical that stimulates lymphocytes to attack viruses and also activates the natural killer cells that attack cancer cells. And interferon is produced by white blood cells known as macrophages that will engulf a virus. Interferon stimulates other cells to produce an antiviral substance that prevents the virus from entering the cell and reproducing. Interferon also stimulates NK or natural killer cells of the immune system to attack cancer cells. So the types of cancers that we treat with biological response modulators include metastatic melanoma, which is a lethal form of skin cancer, as well as renal cell carcinoma, which is a cancer of the kidneys. And adeslucan, which is known as proleukin. This one is actually an interleukin drug. There's also a group of chemotherapy agents that are chemotherapy antibiotic drugs or anti-tumor antibiotics. These are not your normal antibiotics that I just covered in Chapter 9. These are certain types of antibiotics used to kill cancer cells, but they do adversely affect rapidly dividing human cells as well as rapidly dividing cancer cells. The most common cancers that are treated with these drugs including Hodgkin's lymphoma, testicular head and neck cancers, and the prototype drug is dactomycin, which is known as Cosmogen. So myosin, we talked about that with aminoglycosides and macrolides. They have that myosin sound to it, but this is not your normal treat an bacterial infection type of antibiotic. There are chemotherapy enzyme drugs. These are enzymes that will break down the amino acid asparagine, which the cancer cell needs to reproduce. These drugs are most used to treat leukemia, and they include the drug asparaginase, which is known as Elspar, and they have a drug name of JACE or Ginase. And that, again, that ASE means that it's an enzyme, but because it's a cancer, we're adding that G in front to help us identify it's not your run-of-the-mill enzyme. Next are demethylating chemotherapy drugs. They inhibit the enzyme that's needed for a cancer cell to divide, and we use these to treat cancers of the blood cells. And dexitabine, which is Dacogen, and we're looking at a drug stem of cytabine. So we do see there is a little crossover with some of the drugs with the look-alike, sound-alikes. And then we come to hormone chemotherapy drugs. So if I was to teach this in some of my other classes, I would address the alkylating agents, the antimetabolites, the plant alkaloids, which are coming up, the anti-tumor antibiotics, and then hormone-related treatments. So those would be my big 5. And then some of these fall into other areas. So the hormone chemotherapy drugs, they're going to either enhance the level of hormones, or they're going to block hormones and have different impacts on cancers that are hormonally based. So androgen hormones, we have androgen hormone chemotherapy drugs, and we have anti-androgen hormone chemotherapy drugs. So the androgens are based like testosterone. So these androgens, like everywhere else that we've discussed them, are control schedule 3s. They're going to mainly be used to counterbalance female hormones in treating metastatic breast cancer. Things like methyltestosterone and testosterone. So we're looking for drugs that have that drug stem of sterone, like testosterone. Now, an anti-androgen hormone drug is going to block male hormone. So these are going to be used in treating prostate cancer. That includes drugs like bisalutamide, which is known as Casudex, and has a drug stem of lutamide. Now, on the female side, as we're going through, we have aromatase inhibitors. Aromatase, again, is an enzyme. It ends in ase, so that tells us an enzyme. This is a drug that's going to block the enzyme aromatase, which would bind to and inhibit that enzyme. And what happens is estradiol is not produced. So estrogen, estradiol are components that feed into breast cancer. So we're going to block the feeding source, so to speak. So without it, the estradiol can't feed the breast cancer, and the breast cancer cells can't grow. These are only used to treat breast cancer in postmenopausal women. Anastrozole, which is Armidex. The drug stem being Trozol. And then estrogen hormone therapy, chemotherapy drugs, these are going to be female hormones. So estrogen, estradiol, they act in a similar way of the main female hormone, estradiol. These are used for palliative care in patients with advanced breast cancer or advanced prostate cancer. Palliative treatment provides relief from symptoms, but is not intended to cure. So conjugated estrogens, esterified estrogens, and estradiol are drugs that we would use. These are the same drugs we use in treating menopausal symptoms. Then we have our SERMs. So the selective estrogen receptor modulator chemotherapy drugs, they're going to bind to and block, sometimes even destroy estrogen receptors on the surface of an ER-positive breast cancer cell or an estrogen receptor-positive breast cancer cell. The cancer cells are normally stimulated by estrogen, but without estrogen, the breast cancer cells can't grow. So SERMs in this case are used to treat breast cancer. I've talked previously about SERMs in treating osteoporosis. That's when we want to activate the estrogen cell. These are going to block the estrogen receptor. And drugs in this group include drugs like tormenafine, which is Ferestin. Tamoxifen is another drug in this group. They end in afin. Now the hormones, if we can manage the actual release of the hormones, we have drugs that are considered to be gonadotropin releasing hormone agonist chemotherapy drugs. So our body and the endocrine system works primarily through negative feedback. It's kind of like a switch system. Think of it like a thermostat. When the room gets warm, the air conditioning kicks on. But if the room is cooled enough, the air conditioning is going to kick off. So if we have enough of the gonadotropin releasing hormone, your body perceives that you have enough, it's not going to produce more, which could then trigger a cascade of hormones being produced. So we're going to kind of trick our bodies with this. So they compete with the body's naturally produced hormones that maintain homeostasis via negative feedback by tricking the body to not produce testosterone that would feed a prostate cancer, or not to produce estrogen that would feed a breast cancer. So we use these drugs in treating prostate and breast cancer, and Gosserlin, which is known as Zoladex, is the prototype. And then we have progestin hormone therapy drugs, and these are going to work similar as the female hormone progesterone, which is usually produced in the ovary. These drugs are used to treat uterine cancer in females because the progestin is different female hormone than the estradiol that stimulates breast and uterine cancer to grow. So the drugs medroxyprogesterone or megestrol can be used, and those are also used in treating menopausal symptoms. Okay, now I know this slide's overwhelming, right? Kinase inhibitor chemotherapy drugs. So kinase, we see that it ends in ACE. It's an enzyme. We're going to keep this simple. These are all different kinds of things. Kinase are part of a family of enzymes, and that's why there's so many different ones listed. But they act on an amino acid molecule, which can allow a normal cell to turn on or off the signaling pathways that can control cell division and cell growth. So these are going to be used for a variety of different kinds of cancers. Just know that it's blocking an enzyme specific for amino acids. And we see that a lot of them end in nib or gib. We've got the gib, phenib, clib, denib. Now, Olemus is a little different. We use some of these in treating other things like autoimmune disorders. So tacrolimus could be used in treating rheumatoid arthritis or psoriasis. This is a big bite. We're not going into a lot of detail here. These are very specific. I'm kind of focusing more on the more common, more generalized type of chemo drugs. So we're going to move on. The next are the mitosis inhibitor agents. These are sometimes called mitotic inhibitors. So mitosis is the action. Mitotic means pertaining to mitosis. And then these are also known as plant alkaloids because these all come from plants. And there's 4 main groups. We have the taxanes, the topoisomerase 1 and 2 inhibitors, and the vinca alkaloids. So first, we're going to go and talk about the taxanes. So the taxanes disrupt cell division. That's the most easiest way to identify them. And they mostly treat breast cancer, and they include drugs like docetaxel, which is known as Taxotere. They do have the drug stem of Taxol. We have to be careful. There are a lot of look-alike, sound-alike. There's paclitaxel, docetaxel, Taxotere. So we have a lot of look-alike, sound-alikes. The next ones are the topoisomerase 1 inhibitors, and these bind to the enzyme topoisomerase 1 and prevent the cancer cell from dividing. And these are used primarily in treating breast cancer, cervical cancer, ovarian cancer, and lung cancer. And they include the drugs irinotecan, which is known as Campisar, or Onivid, and they have the drug stem of Tecan. Now, the next group are the topoisomerase 2 inhibitors, and they work very similar to the topoisomerase 1s in that they prevent the cancer cell from dividing by blocking a different enzyme. And these are used to treat leukemia and breast cancer. And etoposide, which is Toposar, is the prototype drug. And they have the drug stems of Poside or Rubicin. So doxorubicin and daunorubicin are also in this grouping. And then the last are the vincas. So the vinca alkaloids disrupt the formation of the genetic code, which will inhibit the cancer cell division. These are used to treat leukemia, Hodgkin's and non-Hodgkin's lymphomas, testicular cancer, and lung cancer. And they include drugs like vincristine, which is known as Vincasar, or Marcubo, vinorelbine. They all start with vin as their drug stem. But these are all plant alkaloids. And then I think in your textbook there's an image of the vinca plant with the pretty purple leaves. Now there are other mitotic inhibitor drugs, and those are used to treat breast cancer. Our good old friends, the monoclonal antibodies, which we know all end in, I know you said what it was, it's MAB. That doesn't identify specifically where these drugs are being used. They're affecting an immune response. That's their goal. They will selectively bind only to specific antigens on the surface of a cancer cell. As the monoclonal antibody drug combines with the antigen, it will stop or inhibit the growth of the cancer cell. It may even kill it. So this is helping us with more targeted therapy. So most often, monoclonal antibodies are used to treat multiple myeloma, lymphomas, leukemia, breast cancer, and bladder cancer, and they do end in MAB. And then we have the retinoid drugs. Now, these are primarily used in treating types of skin cancers. Kaposi sarcoma is a type of skin cancer, often occurring in patients with AIDS. And then other types of skin cancers, basal cell carcinoma, melanoma, things like that. And alloretinoin, which is panretin. They're related to vitamin A, and they end in tinoin. And other chemotherapy drugs, these are anything that don't fit into any of the previous groups. We're not going into the whole oncology thing in big depth. This chapter has a lot of information. Use your guided notes. If you're not using them as you're reviewing this lesson, you'll see where my high points are. So we've talked about corticosteroid drugs previously when we talked about inflammation and also in the endocrine system. But corticosteroid drugs are derived from the anti-inflammatory hormone cortisol, which is produced in the adrenal gland. Corticosteroid drugs are given to cancer patients in order to decrease the tissue inflammation caused by the chemotherapy drugs, but they also act directly to suppress production of excess white blood cells, the leukocytes, in patients who have leukemia or lymphoma. They're also used to treat the anemia caused by chemotherapy drugs. We've already discussed these in chapter 14 of the endocrine system. We know that corticosteroids end in -one, -lone, or -cyanide. Now, when creating treatment protocols, so a chemotherapy protocol is usually a combination of agents, sometimes referred to as cocktail therapy, but it's kind of like the how-to directions of treating different types of cancer. So in your book, they gave the example of the CMF protocol. So the CMF protocol is used to treat breast cancer. So it stands for cyclophosphamide, methotrexate, and fluorouracil. So they would use these three drugs together, like in a cocktail formulation. Maybe not all mixed in the same bag, but in the same course of treatment. And again, these are going to be used to treat breast cancer. Unfortunately, cancer chemotherapy drugs can be damaging to our regular healthy cells, and there are lots of side effects. So because they're toxic to healthy cells, as well as those cancer cells, we want to limit the damage of chemotherapy drugs can cause. Drugs that help reverse toxic effects are known as cytoprotective drugs. So a couple of examples of cytoprotective drugs include the drug Mesna, which protects against the actions of ifosfamide or Ifex, which is an an alkylating drug. And then leucovorin treats toxicity after a dose of methotrexate, an anti-metabolite drug. So these are just common rescue agents or cytoprotectant agents that might be used in treating certain types of cancer. One of the complications of chemotherapy is bone marrow suppression. So the rapidly reproducing cells in the bone marrow, which would produce blood cells, can be impacted. So we use a group of drugs that are known as colony stimulating factor drugs or granulocyte colony stimulating factor drugs. And these include drugs that are going to increase production of white blood cells. Those are your leukocyte inducers. Erythrocyte stimulating drugs are going to increase red blood cells, and platelet inducers are going to increase the levels of platelets or thrombocytes, your clotting cells. So when we're going through these, leukocyte inducers are given when a patient has leukopenia, which is a deficiency of white blood cells, or use of chemotherapy leaves them at risk of infection. So we're going to give this to decrease that risk of infection, because what they're going to do is increase those white blood cell productions. Now these drugs end in grastum. So filagrastim is an example, like Neupogen. Your erythrocyte stimulating drugs, they're going to be used for erythrocytopenia, or if somebody has anemia. So we're going to use that to increase red blood cells. Anemia, we discussed with the cardiovascular unit. That's when there's not enough oxygen. The blood's not able to carry enough oxygen. Part of the reason here would be there's not enough red blood cells, because we've affected the production of red blood cells by using chemotherapy drugs. So we want to increase the production of erythrocytes or red blood cells, and now we can carry more oxygen. And that's how it's going to treat the anemia. These drugs, erythropoietin, have the drug stem of poietin. And then the platelet inducers are the newest group, and these are used for thrombocytopenia, or when there's a deficiency of clotting cells. So it's going to increase the ability of the patient to be able, their blood to clot. So it's going to help reduce the bleeding and bruising that can be occurring if they don't have enough of those thrombocytes. These drugs have a drug stem of Trombopac, almost like thrombo in there, except they left the H off, so Trombopac. Some are given injection and some are actually given orally. So we have L-Trombopac is Promacta. And then also we have bisphosphonates that can be used, and these have the drug stem of Dronate. And we talked about these back with bone drugs. So these are used in preventing osteoporosis. But the purpose here is to move calcium from the blood to the bones to help increase bone strength. So again, most often used to treat osteoporosis, but they can be used when someone's bones get weakened by their chemotherapy. One of the most common side effects of chemotherapy is nausea and vomiting. And there's actually a special term known as chemo-induced nausea and vomiting, which is CINV. One of the other main ones can be things like alopecia, loss of hair, or mucositis and sores in the mouth. But talking about nausea and vomiting, which is very common with chemo drugs. So again, these are going to be used for chemo-induced nausea and vomiting. And we can use cannabinoid drugs, which we talked about in the GI system, and I also was just discussing in Chapter 9. Substance P neurokinin receptor antagonists, and then 5-HT3 receptor blockers. So we've already discussed these in the GI system, but just as a reminder, cannabinoid drugs like dronabinol, which is Marinol, or Syndrose. It's a C3 drug. It's a controlled substance. It's the chemical synthetic form of THC. The substance P neurokinin 1 antagonists, aprepitant, which is Synvanti, and we have that chemo-induced nausea and vomiting right in that brand name right there. And these have Pitant as their drug stem, and then your 5-HT3 receptor blockers on ondansetron, which is Zofran, and that has the drug stem of Cetron. So these are going to be used for nausea and vomiting. And now it's time for the questions.